I was rummaging through my pockets earlier today, and I found a euro, and I was looking at the euro, and I noticed that it has the words fraternité, égalité, or liberté, égalité, fraternité. And the slogan comes from the French propaganda during the Revolution: unity and indivisibility of the Republic, liberty, equality, fraternity, or death. Now, what fascinates me is that the more the state proclaims its own unity and its indivisibility, the more it denies the integrity and dignity of the human person. So this next presentation by Dr. Alan Shewmon talks about the insights into integration, what makes an organism whole. Dr. Shewmon is a professor emeritus in neurology and pediatrics at UCLA. His research interests include pediatric epilepsy and neuroethics. On topics related to brain death, he has authored more than 40 publications, served on national and international committees, and given numerous lectures at national and international levels. Many credit him as the one most responsible for the current critical thinking of brain death theory. So without any further ado, Dr. Shewmon.
So thank you so much, Dr. Nguyen, Professor Seifert, and the other organizers for the invitation to participate in this important conference. Thanks also to the technical staff for making this remote participation possible. The brain death debate features several competing concepts or definitions of death. Since a human being is a rational animal, the biological aspects of death are the same for humans as for animals in general. In their seminal paper of 1981, neurologist James Burnett and colleagues defined death as the permanent cessation of functioning of the organism as a whole. I would modify this so as to give priority to ontology over functioning by defining death simply as the cessation of the organism, in the sense of cessation of the being of the organism. Loss of functioning is an accidental change, whereas we are concerned with the substantial change from living organism to the non-living remains of what used to be an organism. Of course, such cessation of being is ipso facto irreversible, barring supernatural intervention, so Burnett's temporally qualifying adjective permanent becomes superfluous. Likewise, a true organism is ipso facto a whole, so the phrase as a whole is also strictly speaking superfluous, although it does emphasize an important aspect. I shall not discuss proposed definitions or criteria of death that focus on the specific difference of man as a rational animal. In other words, definitions based on loss of the capacity for rationality. Professor Seifert has already dealt with this, and it would be beyond the scope of my assigned topic. So let us simply agree for purposes of this talk that irreversible unconsciousness per se does not constitute death. Next slide, please. Key to the biological concept of death is loss of the wholeness or the dynamic integrative unity of an organism. There is no generally accepted philosophy of integration, and what I shall present today is based on a scheme for categorizing integration, which I proposed in a 2012 publication, a link to which is on the conference website. I do not claim that this scheme is philosophically comprehensive, but I do believe it provides a useful and valid framework for investigating whether brain-dead bodies are living organisms or mere collections of partially interacting organs and tissues. Integration can be understood in terms of at least two broad categories, which are conceptually independent, namely level and type of integration. Level of integration can be understood along at least two axes: a structural functional axis and an ontological hierarchical axis. Along the structural functional axis, we have organism, organ, and cellular levels of integration. Perhaps others, but these three suffice for our purposes. Along the ontological hierarchical axis, we have the three classical levels of biological existence and function: vegetative, sensory motor, and intellectual volitional. Applicable to each level are three types of integration. The first and ontologically most important is what we might call life-constituting or constitutive integration, which makes something to be a living whole. Some famous scientists, like Erwin Schrödinger, have proposed that the essential feature distinguishing living from inanimate things is an endogenous active opposition to the general tendency of physical systems toward increasing entropy. Of course, this is not the only distinguishing feature, but it is a key one. So much so that I think a catchy but insightful definition of a living entity is a bubble of anti-entropy in a sea of entropy. Endogenous opposition to entropy requires biochemical energy and results from the mutual interactions of literally thousands or tens of thousands of biochemical components, ranging in complexity from simple ions to giant macromolecules throughout the living entity. These mutual interactions are the life-constituting integration. By contrast, life-sustaining integration helps an already existing thing to stay alive and whole. It comes in two forms: integration that maintains the internal milieu in an optimal state, leaving a wide margin of safety from dysfunction, disease, and death, could be called health-maintaining integration. Most, if not all, visceral organs participate in such a type of integration. Integration that is externally directed could be called survival-promoting, good examples of which are those sensory motor and cognitive functions of the brain, which allow the anticipation and avoidance of danger, the relief of hunger and thirst, and so on. A correlate of life-sustaining integration is substitutability. This is a relative matter. An integrative function can be replaced technologically or pharmacologically or through some other form of assistance, and how well or adequately it substitutes for the natural function is a matter of degree. The health-maintaining integrative role of the thyroid gland, for example, is replaceable with a daily pill of levothyroxine. The survival-promoting integrative function of hearing is partially replaceable through a cochlear implant, and the hearing of speech is substitutable by sign language. I call these integrative functions rather than merely functions, to emphasize both that they derive from lower-level integration within their respective organs, and that they in turn are integrated into the overall life processes of the organism. By contrast, life-constituting integration is absolutely non-substitutable. It occurs diffusely throughout the cell, organ, and organism, depending on what structural functional level is being considered. The endogenous resistance to entropy exemplifies absolute non-substitutability. So also does consciousness, another example of life-constituting integration. If either consciousness or resistance to entropy is present, there is life. Note that by consciousness, I am referring here to the kind of awareness of an adaptive interaction with the environment that humans have in common with animals, not the reflective intellectual self-awareness that is specifically human and derives from the immaterial dimension of the human soul. What type of integration is performed by the brain? As we have just seen, the neural integration underlying consciousness is of the constitutive type, but unconsciousness per se does not mean lack of an integrated organism. In the context of the brain death debate, the question is, what is the brain's role with respect to the integration of the body? Traditional defenders of brain death maintain in essence that not only is the brain-based integration necessary for organism-level constitutive integration, but it is the constitutive integration. Moreover, any residual brain function suffices for organism-level constitutive integration. In other words, an almost but not quite brain-dead person is not dead. Next slide, please. But in what follows, we shall see that, to the contrary, all brain-mediated somatic integration is either of the health-maintaining or survival-promoting type, and the body's constitutive integration is entirely non-brain mediated. The brain exercises its coordinating influences over the body in two ways, either by direct neural control via the spinal cord and peripheral nerves, or by way of the pituitary gland, which is connected to and regulated by the part of the brain called the hypothalamus. How then could integration possibly take place throughout the body without either brain-based coordination or brain-regulated endocrine function? The answer is threefold. First, there is more to the nervous system than the brain. Second, there is more to the endocrine system than the hypothalamic pituitary axis. And third, there is more to the circulatory system than a mere means by which endocrine information is transferred. Next slide. First, there is more to the nervous system than the brain. The spinal cord is no mere passive conduit of brain impulses, but a subsidiary site of integration in its own right. This is especially evident in cases of high spinal cord transection. Acutely following the injury, spinal cord functions shut down below the transection, a condition called spinal shock. This results in marked instability of blood pressure and other autonomic dysfunctions, muscular hypotonia, and absent tendon reflexes. In fact, many of the acute non-endocrinologic somatic disturbances of brain death are due more to spinal shock than to loss of brain-based integration. Over days or weeks, the cord gradually recovers from the spinal shock, and autonomous cord-based control of blood pressure and certain other autonomic functions return, along with muscle tone and tendon reflexes. In fact, the relative stability of the rare cases of chronic brain death is due largely to recovery of cord-mediated somatic integration following spinal shock. But in addition to the central nervous system, the body has two other nervous systems responsible for the integrated functioning of the heart and the gastrointestinal tract, respectively. The cardiac nervous system includes two pacemaker structures and a branching network of nerves that coordinate the contraction of the heart muscle as a functional unit. The enteric nervous system consists of around 100 million neurons, about 1/10 the number in the spinal cord. Its integrative action throughout the digestive tract is so complex that it has been described by some as a, quote, second brain, unquote. Needless to say, all this non-brain-based neural integration is of a non-constitutive type and is substitutable to a greater or lesser degree. Patients without spinal cord function are severely disabled, but they survive with the help of wheelchairs, bladder catheterization, and other forms of assistance. Cardiac pacemaker failure is circumvented by artificial pacemakers, and the entire heart itself can be replaced by an artificial one. Gastrointestinal motility problems may be ameliorated by medication, and in extreme cases, the function of the entire gastrointestinal tract can be substituted by total parenteral nutrition. Perhaps it will come as a surprise, but all brain-mediated somatic integration is also of the non-constitutive variety. Consider the following revealing passage by Dr. Burnett in one of his earlier attempts to explain why a body without brain function is no longer an organism as a whole. It is primarily the brain that is responsible for the functioning of the organism as a whole. Note that he says the functioning, not the being of the organism as a whole. Then he lists the integration of organ and tissue subsystems binaural and neuroendocrine control of temperature, fluids, and electrolytes, nutrition, breathing, circulation, and appropriate responses to danger, among others. The color coding highlights how all of these integrative functions are health maintaining, save one, which is survival promoting. This conclusion is reinforced by the following considerations. The great bulk of the human brain resides in the cerebral hemispheres, which carry out extraordinarily complex integration, all of which is of the survival promoting type from the point of view of the bodily organism. The relatively small brainstem is responsible for the integrative functions that are tested for in clinical brain death examinations. As stated previously, consciousness is a constitutive type of integration, but it is not the only constitutive type, and we agreed in the beginning that irreversible unconsciousness per se was not death, as long as the body remains a living organism as a whole. So the question is whether the brain confers constitutive anti-entropic integration on the body. From the point of view of the bodily organism, consciousness is survival promoting, and in coma that role is substituted by expert medical care and nursing care. Time does not permit review of every brainstem reflex. Suffice it to say that the clinically testable ones are either health-maintaining or survival-promoting. Even breathing is of the health-maintaining type. It takes quite a few minutes between cessation of breathing and death, making clear that breathing does not constitute life, but maintains it. Moreover, breathing is essentially substituted by a mechanical ventilator. But what if the clinically testable brainstem functions are reliable surrogates for untestable or unknown brainstem functions that are constitutively integrating for the body? It is easy to prove that this is not the case by considering the effects on the body of being disconnected from brain-based control. From the point of view of the body, the effects of loss of brain-based integration should be the same, regardless whether that loss is due to brain destruction or brain disconnection. A clinical example of brain disconnection is fulminant Guillain-Barré syndrome, an autoimmune inflammation of the peripheral nerves and nerve roots. In very severe cases, nerve impulses are completely blocked from entering or exiting the spinal cord, functionally disconnecting the central nervous system from the rest of the body, apart from the endocrine functions of the hypothalamic pituitary axis. Such cases have been reported as clinically mimicking brain death. High spinal cord transection is almost as good an example of brain disconnection, the one flaw in the comparison being the parasympathetic innervation of many viscera by the 10th cranial nerve, the vagus nerve. To complete the analogy, we could imagine a drug like atropine being administered to suppress vagus nerve function, as is actually sometimes done therapeutically in these patients. And to make both examples 100% analogous to brain destruction, suppose that the patient who suffered either calamity happened to be someone with pituitary failure who had been followed in an endocrinology clinic and was leading a normal life on replacement hormones. Now, every medical professional caring for this unfortunate person in the intensive care unit knows that they are caring for a very sick, living human being. But according to brain death theory, such an individual would have to be regarded as a conscious brain in a dead, decomposing corpse. The logical conclusion is that if a brain-disconnected body retains constitutive integration by virtue of something other than brain function, then so does a brain-destroyed body. Examples of brain function without structural damage also provide insight into the necessity, or lack thereof, of brain-based integration for somatic unity. Neurological criteria for death everywhere in the world require that the loss of all brain functions be irreversible. No doubt because death itself is by definition irreversible. Ironically, this requirement actually undermines the integrative unity rationale. If that rationale were correct, the body should begin to disintegrate immediately upon loss of all brain-based integration, whether that loss be irreversible or reversible, permanent or temporary. Suppose, hypothetically, that a general anesthetic were administered at such a high dose as to suppress essentially all brain function. Such a patient would require expert anesthesiology and intensive care, and no one would diagnose the patient as brain dead because all diagnostic protocols require that reversible causes be excluded. Nevertheless, the body is not receiving any integrative influences from the brain for as long as the anesthetic is maintained. This example puts brain death defenders in a bind because they can analyze the scenario in only 3 possible ways, all of which are incompatible with their hypothesis. They could say that since integrative brain function is absent, the body must be already disintegrating. In other words, the anesthesiologist killed the patient, regardless of the fact that the patient will make a full recovery after lifting of the anesthesia, a true Lazarus phenomenon. Or they could say that there is a latency between the loss of brain function and the beginning of somatic disintegration, and therefore a short period of time without brain function would not constitute a loss of integrative unity and death. But how long would it take for the loss of brain functions to produce the deadly effect? Many defenders of brain death emphasize how so many brain-dead patients succumb to cardiac arrest within as little as 24 to 48 hours. So suppose the anesthesiologist maintained the anesthesia for that long. Then the defenders are right back to the previous dilemma. More importantly, this form of explanation would amount to an admission that the death consisted in something other than the loss of brain-based integration. Or they could simply concede that somatic integrative unity is not lost upon cessation of all brain functions after all. The fact that reversible, sustained loss of all brain functions is recognized by all as not death implies that brain-based somatic integration is entirely of the non-constitutive type. Patients in acute brain death tend to be physiologically very unstable, and, as just mentioned, many succumb to cardiac arrest during the first 24 or 48 hours, despite resuscitative efforts. Defenders of the integrative unity rationale often cite this as evidence that the brain is indeed the body's critical integrator. But there are more plausible explanations for the acute instabilities. Spinal shock has already been mentioned as one factor, but there are others. For example, direct multi-system damage from whatever caused the brain injury, typically severe trauma or cardiorespiratory arrest. Apnea at the time of injury can cause further damage from hypoxia. The process of brain herniation, prior to reaching its endpoint of total brain destruction, can cause neurogenic pulmonary edema and so-called sympathetic storm, which can damage multiple organs, especially the heart, through subendocardial microinfarcts. Another kind of physiologic disturbance is a generalized inflammatory response. This is not specific for brain death, however, as it occurs in serious brain injuries short of brain death, and like inflammatory responses in general, it is transient in patients who survive longer than a few days. Finally, as Dr. Coimbra has often pointed out, thyroid and adrenal insufficiency, which are common in these patients yet rarely tested for or treated, can cause additional somatic dysfunction and instability. Clearly, many, if not most, of the physiologic instabilities that challenge the clinical management of brain-dead organ donors result not from loss of brain-mediated integration, but from direct or indirect damage to multiple vital organs. Even the generalized inflammatory response from exposure of the immune system to damaged brain tissue is due to reasons other than loss of brain-based integrative control over the immune system. These acute instabilities, therefore, cannot be cited as evidence that the mere lack of integrative brain functions per se is what makes some of these bodies literally disintegrate. Moreover, the acute instabilities do not last forever in patients who are supported for prolonged periods of time. Many patients certainly do succumb early, but in those who survive more than a few days, the most serious systemic dysfunctions gradually self-resolve, again indicating that they were due to something other than the mere absence of brain control. Neurologist Ilko Vidics wrote, "The main objectives in the medical support of brain-dead organ donors remain the maintenance of oxygenation, the circulation, and control of polyuria and control of hyperglycemia. The overriding principle is maintenance of normal or near-normal physiology. Therefore, several acute processes can and should be reversed. That normal or near-normal physiology can be maintained by means of technological replacement of so few integrative functions indicates clearly that the missing integration is of the health-maintaining, not life-constituting type." Apart from direct neural control via the spinal cord, the other avenue, and the only other one, by which the brain carries out bodily integration is through the endocrine system, to which we now turn. The endocrine system, singular, is actually a misnomer. The term is merely a convenient catch-all for several relatively independent endocrine systems, plural, only one of which is brain-regulated, namely the hypothalamic pituitary axis. The pituitary gland sits at the base of the brain in the middle of the head and is connected by a stalk to the part of the brain called the hypothalamus. The anterior lobe of the pituitary secretes a variety of hormones into the bloodstream, governed by locally acting hypothalamic releasing and inhibiting factors. The posterior lobe is actually an extension of the hypothalamus itself. It releases two hormones directly into the bloodstream: antidiuretic hormone, ADH, which regulates water balance by the kidneys, and oxytocin, which is involved in sexual reproduction and childbirth. Of all the pituitary hormones, the most important, and virtually the only one that receives any attention in clinical brain death, is antidiuretic hormone, also known as vasopressin. Absence of antidiuretic hormone results in a condition called diabetes insipidus, in which the kidneys produce an outpouring of dilute urine, resulting in dehydration and electrolyte disturbances if left untreated. Remarkably, in brain death, despite hypothalamic destruction or near destruction, pituitary functions are variably preserved. Endocrinologic studies in clinical brain death have consistently shown that panhypopituitarism virtually never occurs. This is generally attributed to the fact that the pituitary gland receives a dual blood supply from both intra- and extradural arteries, the latter being unaffected by the increased intracranial pressure associated with brain death. Collaterals from the extradural arteries may keep even small portions of the hypothalamus itself viable and functioning, resulting in absence of diabetes insipidus in about 1/3 of cases. Of all the pituitary hormones, only 3 are necessary for survival, in the sense that their end organ functions are necessary for survival, namely thyroid-stimulating hormone, TSH, adrenocorticotropic hormone, ACTH, and antidiuretic hormone, ADH. It takes days to weeks to die from their absence, and they are easily replaceable pharmacologically. The integrative role of all 3 is clearly of the health-maintaining type. Don't worry about the details of this slide. I made it intentionally busy to illustrate the number of relatively independent endocrine systems that function autonomously from the brain. They involve multiple organs, including the heart, lungs, gastrointestinal system, liver, kidneys, adrenals, thyroid, parathyroids, bone marrow, skin, and adipose tissue. And this list does not even pretend to be complete. As with the hypothalamic pituitary axis, the type of integration carried out by all these non-brain regulated endocrine systems is of the health-maintaining type. We turn now to the circulatory system, which, as regards somatic integrative unity, is much more than a mere vehicle for distributing integrative endocrine information. First of all, the circulatory system reaches and interconnects essentially all the parts of the body, something that cannot be said for the nervous system, which does not extend into the bloodstream or bone marrow, for example. Moreover, circulation is the means of the intercellular biochemical communication responsible for both homeostasis, the maintenance of stability of physiological parameters, and resistance to entropy. By means of circulation, oxygen and biochemical fuel are distributed to all cells for the production of energy, a sine qua non for anti-entropy. And carbon dioxide and biochemical wastes from that energy production are removed. Circulation also distributes the necessary biochemical substrates for the orderly turnover and self-assembly of bodily components, which is also part and parcel of the life process. And it removes the breakdown products from that turnover. Circulation is not the integration itself, rather the homeostatic, anti-entropic mutual interactions among all the parts of the body are the integration. Clearly, such integration is of the life-constituting type, and it is inherently not substitutable by any technology. Having established that circulation, not brain function, is the sine qua non for constitutive integration, the next question is, what level of life is constituted by the anti-entropic interactions via the circulation, in the absence of all brain function? For indeed, constitutive integration can and does occur at all hierarchical levels, from organism down to cell. The mere fact that circulation-mediated integration is constitutive and reaches all body parts does not per se establish that the integration is at the level of the organism as a whole. The question boils down to whether the loss of brain-mediated health-maintaining or survival-promoting integration could cause the level of circulation-mediated constitutive integration to drop from organism to organ. Advocates of brain death maintain that it does. In the words of Burnett, the cardiac arrest patient with whole brain destruction is simply a preparation of unintegrated individual subsystems, since the organism as a whole has ceased functioning. This idea is sometimes expressed with colorful, hyperbolic rhetorical flair. For example, some have written that a brain-dead body is nothing more than, quote, a ventilator keeping a heart beating in a corpse, unquote, or, quote, a magnificent cell culture, unquote. Most recently, biologist Maureen Kondik proposed a distinction between integration and coordination. In her terminology, integration refers to what I have been calling constitutive integration at the level of the organism, while coordination refers to all other kinds of interactions among bodily constituents. She maintains that brain-dead bodies are, quote, a mere aggregation of human cells, unquote, which are coordinated but not integrated. Such assertions are made without evidentiary backing. In the final consequence, they are a form of the logical fallacy petitio principii, or begging the question. Let us now explore how one might go about scientifically determining level of integration and apply this method to the empirical evidence of brain-dead bodies. Integration occurs across a continuum of degrees of robustness, which for the sake of visual simplicity we could represent by a line segment, with the far left end representing a healthy organism, the far right end representing a decomposing corpse, and somewhere in between representing the discontinuous transition from integrated organism as a whole to disintegrating collection of organs and tissues. Of course, the biological reality is much more complicated, and a more realistic representation would be a multidimensional space with a multidimensional boundary separating organism as a whole from non-organism. But the linear diagram suffices to illustrate the point. Our question is, how do we determine where along the continuum a given entity X lies? More importantly, and also a more tractable question, how do we determine on which side of the dividing line X lies? Unfortunately, biology has not come up with any operational definition or method of measurement of degree or level of integration, so we must resort to indirect criteria. In 2001, I published 2 such criteria. I believe their validity is self-evident, and in the intervening years, no one has challenged their validity, although some of my critics have challenged their application to the empirical facts surrounding brain death. The first criterion is as follows. Integrative unity is possessed by a putative organism if it possesses at least one emergent holistic level property. A property is defined as emergent if it derives from the mutual interaction of the parts, and as holistic if it is not predicable of any part or subset of parts, but only of the entire composite. Let us apply this criterion to the rare but instructive cases of chronic brain death, where for various reasons there was a motivation to support the patient in this state for a prolonged period of time, or even indefinitely. In 1998, I published a series of around 175 reported cases of brain death with survivals longer than 1 week, a few of which I had detailed personal knowledge of. Some of them were even discharged from the hospital and maintained at home for months or years with nothing more than ventilatory support, tube feedings, a few medications, and good nursing care. Although criterion 1 requires only a single holistic property, these cases manifested many such properties, including homeostasis, the maintenance within life-compatible ranges of countless physiological parameters, ions, and biochemicals without monitoring or therapeutic adjustment. Assimilation of nutrients and elimination of wastes. Temperature maintenance, albeit in a slightly subnormal range and with the help of blankets. Cardiovascular and autonomic regulation, manifested by spontaneous stabilization from the acute hypotension, with ability to wean off pressor medications, toleration of a sitting position, and coordinated responses to stress, such as unanesthetized incision for organ retrieval. Spontaneous improvement in general health after the initial acute phase. Teleological wound healing. Proportional growth of children as opposed to chaotic growth like that of a tumor. Onset of puberty in a few pediatric cases. Successful gestation of a fetus in brain-dead women. Febrile response to and overcoming of infections. A relative paucity of medical complications. The ability to recover from medical crises such as tracheal obstruction or septic shock. And finally, the sheer ability to survive for a prolonged period of time with little medical intervention in a nursing facility or even at home. The President's Council on Bioethics was impressed enough with this list of holistic functions that it concluded in 2008, if being alive as a biological organism requires being a whole that is more than the mere sum of its parts, then it would be difficult to deny that the body of a patient with total brain failure can still be alive, at least in some cases. Countering this argument, Maureen Kondik listed many of the same functions and stated, quote, "Yet all of the functions listed in Table 1 are either seen in isolated cells and tissues maintained in culture, or are known to be due to chemical signals that could easily be reproduced in the laboratory. The fact that these activities are also seen in human cells or tissues ex vivo indicates that they are not sufficient for determining whether or not a human is still alive. That is, whether or not what remains after brain death is still a human organism as a whole, rather than an aggregation of unintegrated cells and tissues that used to be part of the unified human organism," unquote. In reply, I would make the following points. Firstly, Kondik provides no references for any of the yes assertions in her table. Some seem rather far-fetched as attributed to cell or tissue cultures. In any case, suppose for the sake of argument that we even give Table 1 the benefit of the doubt for being factually correct. But secondly, Table 1 misses the whole point. Even if we grant, for example, that a living cell maintains its own internal milieu within physiological ranges, that is, homeostasis at the cellular level, so what? Kondik's implication seems to be that, therefore, homeostasis at the level of the organism is essentially nothing more than the sum of cellular homeostasis. But that doesn't logically follow. Similar points could be made about the other listed functions. Even if we grant that some of these functions, or components of these functions, as she qualifies them, occur in explanted cells, that doesn't mean that if they, and not just some components of them, occur diffusely and emergently throughout a multicellular organism, they are not holistic at the level of the organism. Kondik is an experimental biologist, and she writes about the kinds of things she deals with in the laboratory. Physicians deal with patients, not tissue cultures, and the holistic functions listed in the previous several slides are at the level of the organism as a whole, not the cell as a whole. Thirdly, after rejecting all these functions as mere coordination, she asserts without proof that only brain-based control provides true integration of a human organism. This is an example par excellence of question begging, if there ever was one. The second indirect criterion for determining which side of the dividing line between living and dead an entity falls is the following. Any body requiring less technological assistance to maintain its vital functions than some similar body that is nevertheless a living whole must possess at least as much integration and hence also be a living whole. In terms of our diagram, this can be translated as follows. If A has more integration than B, and B is on the integrated whole side of the dividing line, then A is necessarily also on the whole side. Let us apply this second criterion to two real clinical scenarios. Take for reference entity B, a patient in an intensive care unit with end-stage metastatic cancer, in septic shock, comatose, and ventilator dependent. Pressor medications are required to maintain blood pressure, and she is on multiple other medications. She has multi-organ failure and disseminated intravascular coagulation. Because of intestinal ileus, she can be nourished and hydrated only intravenously. Her medical management is extremely complex, requiring great expertise. She is in the terminal phase of her disease, and everyone on the medical team knows that all their efforts to save her will soon prove futile. Although permanently comatose, she is not brain dead. Although implacably dying, she is not yet dead. Now compare that with entity A, one of the cases of chronic brain death being cared for stably at home or perhaps in a skilled nursing facility. Blood pressure is maintained spontaneously without pharmacologic support. The patient requires relatively few medications. All the non-brain organs are functioning normally. Intestinal motility is present, and tube feedings provide effective nourishment. The medical management otherwise consists of ventilatory support and basic nursing care. The patient has been in this condition stably for several months already and shows no signs of deterioration. Brain-dead patient A clearly requires less technological support than imminently dying patient B. So according to criterion 2, she clearly falls even more to the left of the whole side of the dividing line. Nevertheless, according to mainstream brain death theory, patient A is nothing more than a ventilator keeping a heart beating in a corpse, or a magnificent cell culture. Criterion 2 exposes such non-scientific rhetoric for what it is. The typical acute brain death case, A prime, would fall somewhere between A and B, clearly still to the left of the dividing line. In conclusion, the brain is not the body's thermodynamically critical organ. In fact, the body has no such critical organ. All brain-based somatic integration is either of the health-maintaining or survival-promoting type. The body's life-constituting integration is the anti-entropic mutual interactions among all its parts, mediated by circulation. And finally, brain-dead patients are severely disabled, totally dependent, tenuously alive human organisms. Thank you.